Hello everyone, we are the student of Shivajirao Jondhle College of Pharmacy. This project is highlighting the research on tuberculosis, its pathophysiology, treatment, and modern developments in the treatment. This project is prepared by Shyam Chaudhary, Sohan Chaudhary, Swarupa Chopade, and Vidya Dalvi. So, first of all, we will see what is TB. It is a chronic granulomatous communicable disease caused by Mycobacterium tuberculosis that mainly affects the lungs. It is a contagious disease. So currently, TB occurs in every part of the world. In 2020, the largest number of new TB cases occurred in Southeast Asian region with 43% of new cases, followed by the African region with 25% of new cases and Western Pacific with 18%. In 2020, 86% of new TB cases occurred in 30 high TB burden countries. 8 countries accounted for two-thirds of the new TB cases: India, China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. So, now we will see the drugs used for treating TB. These are the drugs used to treat TB, an infectious disease that mainly affect the lungs. TB control requires new drugs that act at novel drug target to help combat resistance forms of Mycobacterium tuberculosis and reduce the treatment duration. Drug resistant strains of the Mycobacterium are not susceptible to the current cocktail of the drugs available. So now we will see classification of anti-TB drugs. According to clinical utility, the anti-TB drugs can be classified as first-line drugs and second-line drugs. First-line drugs. These drugs have high antitubercular efficacy as well as low toxicity, are routinely used. Examples of first-line drugs include Isoniazide, Rifampicine, Pyrazinamide, Ethambutol, and Streptomycin. Second-line drugs. These drugs have either low antitubercular efficacy or higher toxicity or both and are used as reserve drugs. Second-line drugs include para-aminosalicylic acid, cycloserine, kanamycin, amikacin, ciprofloxacin, ofloxacin, clarithromycin, and azithromycin. Now, further on, my teammate Vidya will take over to explain the drugs.
So our first and the most important drug is isoniazid. Isoniazid is the single most important drug used in tuberculosis. Isoniazid is nothing but isonicotinic acid hydrazide. So just because of hydrazide, it is represented by H. It is isonicotinic acid derivative, highly effective anti-tubercular drug, effective against both intracellular and extracellular bacilli. In structure, as you can see, pyridine is a basic nucleus which is six-membered ring having first position nitrogen. At position 4, carbonyl group is attached with NHNH2, that is hydrazide. So combined name becomes carbohydrazide. So its IUPAC name is pyridine 4-carbohydrazide. Now let's discuss about mechanism of action. Isoniazid is a prodrug which is activated by Mycobacterial catalyst peroxidase, which is represented by CATG, and the activated INH inhibits two enzymes. First is acyl protein carrier reductase, which is represented by ACPM, and second is acyl protein carrier kinase, which is represented by KAS. These two enzymes are required for mycolic acid synthesis. This mycolic acid is the essential component of microbacterial cell wall synthesis. Thus, by inhibiting mycolic acid synthesis, INH actually produces bactericidal effects. So, if there is no mycolic acid, it will not be able to make new bacteria. That's how INH disrupt the bacterial cell wall formation and kill the bacteria. Now, let's have a look at the uses one by one. As a single agent, is also indicated for treatment of latent TB by positive tuberculin skin test. It is routinely recommended for very young children, person who test positive within 2 years after a documented negative skin test. It is also used in immunocompromised individual, that is in HIV. The major side effects: hepatitis, that is an inflammation of the liver. It is rare in children. but more common in older people and in alcoholics. INH hepatotoxicity is due to dose-related damage to liver cells, but irreversible on stopping the growth. Peripheral neuritis is a condition where pain arises due to nerve damage in hands and feet. Now let's see what the body does to the drug. Isoniazide readily absorbs following oral administration. It is distributed all over body cavities and cerebrospinal fluid. It also crosses placenta. Metabolized by liver, isoniazid is acetylated by N-acetyltransferase to N-acetyl isoniazate. It is then biotransferred to isonicotinic acid and monoacetylhydrazine. Monoacetylhydrazine is associated with hepatotoxicity via formation of a reactive intermediate metabolite when N-hydroxylated by the cytochrome P450 mixed oxidase system. Its route of excretion is kidney. From 50 to 70% of a dose of isoniazid is excreted in urine within 24 hours. Fast acetylators have 0.5 to 1.6 hours of half-life and slow acetylators have 2 to 5 hours of half-life. It is available in tablet form of 500 mg, 100 mg, 300 mg. In oral syrups of 50 mg per ml. Injectable solutions 100 mg per ml. Isoniazid had the brand names like Isonarif, Isotamine and Isotamine B. We have shown here marketed preparation of isoniazid tablet IP. Here are some safety precautions. Is it safe in children? No. It is important that you tell your doctor and pharmacist if your children takes any other medication. Is it safe in lactating mother? Yes. It is considered safe during lactating, but limited data is available on the transfer of isoniazid from circulation to milk in lactating women. Is it safe in pregnancy? No. It is not recommended for pregnant women or women expecting to be pregnant within next 3 months. So our next first line drug is Rifampicine. Have a look at its structure. This drug has a very specific chemical structure. Molecular formula C43 H58 N4O12. In IUPAC name, stereo centers labeled as R and S. EZ configuration describes the stereochemistry of double bonds. Now let's see how it works. Rifampicine binds to beta subunits of DNA-dependent RNA polymerase. DNA-dependent RNA polymerase is an essential enzyme of transcription of replicating systems of organisms. mRNA is the molecule that carries the message contained within DNA to the ribosome. mRNA is important because ribosomes can't reach the DNA inside bacterial cell nucleus. So after binding, it inhibits the mRNA synthesis and shows the tuberculosidal effect. That means it inhibits the activity of microorganisms. It cannot bind to human RNA polymerase, thus selectively destroying the bacteria only. Uses of rifampicin. It is used in treatment of TB in combination with INH and pyrazinamide. It has activity against many gram-positive and negative bacteria but should be used only against TB to prevent development of resistance. In the treatment of leprosy in combination with dapsone and clofazimine. Prophylactic for meningitis caused by meningococci or H. influenzae means it's intended to prevent inflammation of meninges, that is the 3 thin layers of tissue that covers and protect the brain and spinal cord. Side effects: hepatotoxicity, which is rare, abnormal liver enzymes, jaundice, etc., especially in old patients and patients with chronic liver disease. Microsomal enzyme induction leading to decreased half-lives of other drugs. Flu-like symptoms with intermittent therapy. Red tears and urine, which is harmless but can stain contact lenses. GIT upset and skin rashes. Let's discuss its pharmacokinetics. It is well absorbed from gastrointestinal tract. Protein binding is 89%. Volume of distribution is 0.85 liter per kg. It is metabolized by liver, primarily hepatic, rapidly deacetylated. Route of excretion is kidney. Less than 30% of the dose is excreted in the urine as rifampicine or metabolites. Half-life 3.35 hours. Clearance is 0.19 plus or minus 0.06 liter per hour per kg and 0.14 plus or minus 0.03 liter per hour per kg. The dosage forms are capsule in 150 mg or 300 mg and injectable powder in 600 mg. Brand names are Rifadin, Rifamate, Rifater and Rufact. I have shown here marketed preparation. Rifampicine 300 mg capsule. Safety precautions. Is it safe in children? No. It is important that you tell your doctor and pharmacist if your children takes any other medication. Is it safe in lactating mother? No. Breastfeeding should not be discouraged in women taking rifampicine. Is it safe in pregnancy? No. This drug should not be used during pregnancy unless the benefit the risk to the fetus.
Pyrazinamide. Here the structure of pyrazinamide, molecular formula C5H5N3O, IUPAC name 2-pyrazine carboxamide. Pharmacodynamics, mechanism of action. Pyrazinamide diffuses into active M tuberculosis that express pyrazinamidase enzyme that converts pyrazinamide to the active form of pyrazinoic acid. After that, pyrazinoic acid can leak out under acidic condition to be converted to the protonated conjugated acid, which is readily diffused back into the bacilli and accumulate intracellularly. The net effect is that more pyrazinoic acid accumulates inside the bacillus at acid pH than at neutral pH. Pyrazinoic acid to inhibit the enzyme fatty acid synthesis, which is required by the bacterium to synthesize fatty acids. However, this theory was thought to have been discounted. However, further studies reproduced the results of fatty acid synthase inhibition as the putative mechanism, first in whole cell assay of replicating M. tuberculosis bacilli, which have shown that pyrazinic acid and its ester inhibit the synthesis of fatty acids. Pyrazinamide and its analogues inhibit the activity of purified fatty acid synthase. It has also been suggested that the accumulation of pyrazinoic acid disrupts membrane potential and interferes with energy production necessary for survival of M. tuberculosis at an acidic site of infection. Pyrazinoic acid has also been shown to bind to the ribosomal protein S1 and inhibit translation. This may explain the ability of the drug to kill dormant microbacteria. Uses of pyrazinamide. Pyrazinamide kills or stops the growth of certain bacteria that cause tuberculosis. It is used with other drugs to treat tuberculosis in combination with isoniazide and rifampicine to minimize resistance. Here some side effects of pyrazinamide: nausea, vomiting, loss of appetite, mild muscle, joint pain, effect persists, gastrointestinal intolerance. Hepatotoxicity is the major side effect. Hyperuremia and gout due to decreased uric acid excretion. Pharmacokinetics. Absorption rapidly and well absorbed from the gastrointestinal tract. Protein binding 10%, bound to plasma protein. Metabolism. It occurs in liver, hepatic. Route of excretion. It occurs through the kidney. Approximately 70% of an oral dose is excreted in the urine, mainly by glomerular filtration within 24 hours. Half-life 9 to 10 hours in normal condition. Dosage forms: tablet 500 mg, brand names Rifafter and Tebrazid. Safety precautions of pyrazinamide. It is not safe in children. There are some medications that should not be taken together with pyrazinamide. It is important that you tell your doctor and pharmacist if your children takes any other medication. It is not safe in lactating mother. Breastfeeding should not be discouraged in women taking this drug. It is safe in pregnancy. Pyrazinamide is recommended for the use of pregnancy. Ethambutol. Here the structure of ethambutol. Molecular formula C10H24N2O2. IUPAC name 2S 2-S 2 2-ethane 1,2 dial diimino dibutane 1-on. Pharmacodynamics. Mechanism of action of ethambutol. Ethambutol is bacteriostatic against actively growing TB bacilli. It works by obstructing the formation of cell wall. Mycolic acids attach to the 5-hydroxyl group of D-arabinose residue of arabinogalactan and form mycoyl arabinogalactan peptidoglycan complex in the cell wall. It disrupts arabinogalactan synthesis by inhibiting the enzyme arabinosyl transferase. Disruptions of the arabinogalactan synthesis inhibit the formation of the complex and leads to increased permeability of the cell wall. Uses of ethambutol. It is used with other medication to treat tuberculosis. In treatment of TB in combination with isoniazide and rifampicine to minimize resistance. Here are some side effects of ethambutol. Peripheral neuropathy and visual disturbances. Optic neuropathy manifested by field defects and red-green color blindness. These effects are reversible on stopping the drugs. Hyperuremia and gout due to uric acid excretion. GIT disturbance and hypersensitivity reactions. Pharmacokinetics Absorption. Oral ethambutol is approximately 75 to 80% orally bioavailable. A 25 mg per kg oral dose of ethambutol reaches the maximum concentration 2 to 5 microgram per ml with the time taken to reach the maximum concentration is 2 to 4 hours. Distribution. Volume of distribution. Patients co-infected with tuberculosis and HIV have an estimate ethambutol volume of distribution of 76.2 liter per kg. Protein binding. Ethambutol is 20 to 30% bound to protein in plasma. Metabolism. It occurs in liver. Ethambutol is mainly oxidized by an aldehyde dehydrogenase to an aldehyde metabolite, followed by conversion to the dicarboxylic acid to 2-ethylene diimino dibutyric acid. Route of excretion. It occurs through the kidney. Ethambutol is 50% eliminated in the urine as an unmetabolized parent compound and 8 to 15% as inactive metabolites. 20 to 22% of a dose is eliminated unchanged in the feces. Half-life. Ethambutol has a half-life of 3.3 hours in patients with normal renal function. In patients with renal failure, the half-life could be 7 hours or longer. Dosage forms. Tablets 100 mg or 400 mg. Brand names ETB and Myambutol. Precautions in ethambutol. It is not safe in children. Ethambutol should not be given to a child younger than 13 years old. It is not safe in lactating mother. Breastfeeding should not be discouraged in women taking this drug. It is safe in pregnancy, have an excellent safety record in pregnancy, and are not associated with human fetal. Second line drugs ciprofloxacin. Here the structure of ciproflexacin, molecular formula C17H18FN3O3, IUPAC name 1-cyclopropyl 6-fluoro 1,4 dihydro 4-oxo 7,1-pipranidyl 3-quinoline carboxylic acid. Pharmacodynamics. Mechanism of action of ciproflexacin. Ciproflexacin acts on bacterial topoisomerase II and topoisomerase 4. Ciproflexacin's targeting of the alpha subunits of DNA gyrase prevents it from supercooling the bacterial DNA, which prevents DNA replication. Uses of ciprofloxacin. Ciprofloxacin is used to treat a variety of bacterial infections. It belongs to a class of drugs called quinoline antibiotics. It works by stopping the growth of bacteria. Here are some side effects of ciprofloxacin: fast heartbeats, fluttering in your chest, shortness of breath, and sudden dizziness. Any skin rash, muscle weakness, breathing problem. Little or no urination. Jaundice. Common ciprofloxacin side effects may include nausea, vomiting, diarrhea, stomach pain, etc. Pharmacokinetics absorption. A 250 mg oral dose of ciprofloxacin reach an average maximum concentration of 0.94 mg per liter in 0.81 hours, with an average area under the curve of 1.013 liter per kg. An early review of ciprofloxacin reported an oral bioavailability of 64 to 85%, but recommended 70% for all practical uses. Distribution. Volume of distribution. Ciprofloxacin follow a 3-compartment distribution model with a central compartment volume of 0.161 liter per kg and a total volume of distribution of 2 to 3.04 liter per kg. Half-life. The average half-life following a 250 mg oral dose was 3.7 to 4.71. Protein binding 20 to 40%. Metabolism occurs in liver. Route of excretion. Excretion is occurs through the kidney. 27% of an oral dose was recovered unmetabolized in urine compared to 46% of intravenous dose. Dosage form. Infusion solutions 200 mg to 100 mg. Oral suspension 250 mg per 5 ml. Tablet 100 mg adults only or 250 mg. Brand name Citraxel, Siloxane and Cipro. Safety precautions. It is safe in children. Ciprofloxacin can be taken by most adults and children from age of 1 year. It is safe in lactating mother. There does not seem to be an increased chance for harmful effect. It is safe in pregnancy. There are no controlled studies of ciprofloxacin is used in pregnant women to show safety. Modern treatment techniques in TB. Drug-sensitive TB. Category 1 new patients not exposed to anti-TB drugs. Category 2 old patient exposed to anti-TB drugs. Treatment phase. Intensive phase and continuous phase. How intensive phase and continuous phase treatments in Cat 1 and Cat 2 people of drug sensitive TB are so different from previous guidelines and current guidelines. 2016 guidelines. H. Isoniazide, R. Rifampicine, Z. Pyrazinamide, E. Ethambutol, S. Streptomycin. Phase. Cat 1 in intensive phase 2 HRZE and Cat 1 in continuous phase is 4 HRE. Cat 2 in intensive phase 3 months 2 HRZE plus 1 HRZE and Cat 2 in continuous phase is 5 HRE. 2018 guidelines. Phase. Cat 1 in intensive phase 2 HRZE and Cat 1 in continuous phase is 4 HRE. Cat 2 in intensive phase is 2 HRZE and Cat 2 in continuous phase is 4 HRE. Acknowledgement. We are thankful to our President, Honorable Dr. Shivajirao Jondhle Sir, and Secretary Honorable Dr. Geeta Khare Ma'am, and Principal of our college, Dr. Nitin Mohire Sir, for encouragement and guidance.